Hi, I'm Steve Kareha, for those of you who don't know me. And this is Physical Therapy Grand Rounds. This is the second month we've done it. And just as in past months, we will be recording this, so if you want to look at it again, feel free. Today we have Dr. Laura Rothermel talking about rib dysfunctions. If you have any questions and you're online, please type them in, and we'll be happy to answer them. And towards the end. All right, and without further ado, here's Dr. Rothermel.
Thank you. Thank you, everybody, for coming out this morning for this talk on rib dysfunctions. If you have any questions throughout the lecture, you can just raise your hand or wait till the end. We'll try to get them all answered before you leave today. All right. So this disclaimer. Basically, there's no financial relationships to disclose. The objectives of the talk today are going to be describing the clinical anatomy of the thoracic spine and rib cage to allow for accurate exam, discussing regional interdependence, and describing some manual therapy options. Just for introduction, to talk about the thoracic spine, it's stiffer and less mobile than the rest of the spine, and that is due to the presence of the rib cage. And the rib cage is very important to protect our internal organs, but it does cause the stiffness that resolves in some joint dysfunctions. The spinal canal is relatively narrow, especially in the midsection between T4 and T9, and this can create a tension point, which is basically significant decrease in motion in the spinal cord and the surrounding structures. The reason why that is important to note is because that can make a very vulnerable site with the nervous system when there's an injury. So that's an area that we should look at to address. Reviewing the anatomy of the ribs, ribs 1 through 7 are joined to the sternum by individual costal cartilage, ribs 8 to 10 by fused costal cartilage, and the 11th and 12th rib are free-floating anteriorly. They are important, though, because they do provide attachments for the diaphragm and other trunk musculature. All right. Now we're just going to discuss some joints. So we have the sternocostal joints, the costotransverse joints, and the costochondral joints. As far as the sternocostal joints, rib 1, where it meets with the sternum, is a synchondrosis. This is important to note because it does increase the stability of the upper thoracic spine. So that's why a lot of times you get the increased stiffness and mobility in the CTJ region. The costotransverse joints are synovial joints. They typically, the capsule of the joints is very weak, but it is strengthened by the ligaments, and you also need the support of the surrounding muscles. So that's one concern. And then the costochondral joints, they connect the bony part of the rib to the cartilaginous part, and this does not allow for a lot of movement. Rib 1 is the smallest rib. It is the most massive rib. It's actually oriented inferiorly, which is going to be important when you're doing mobs to make sure that you're mobing in the correct direction. And it is the most curved of all the ribs. Ribs 2 through 9 are considered the typical ribs. The upper border of the shaft of ribs 2 through 9 is rounded and blunt, whereas the lower border tends to be thinner and sharper. And 11 and 12, there's no joint surface for articulation with the transverse process, so you lose actually one of the joints in the back there. Okay, costovertebral joints and costotransverse joints, they form what's called a linked joint in the back, and that creates an axis for the ribs to swivel, and that allows the ribs to move during inhalation and exhalation. There is the pump handle and bucket handle description for breathing. It's basically describing the motion, the elevation of the ribs in the upper thoracic spine. When you're inhaling, it's increasing the anterior posterior diameter of the chest, and the bucket handle, which is the lower thoracic spine, when you're elevating the ribs, it's basically increased the transverse diameter. inspiration and expiration, I listed the primary muscles and accessory muscles. One thing to note, the expiration, it's mostly due to a passive recoil of the rib cage. So you really, unless you're doing like a forced expiration, that's when you'll get a lot of the muscular involvement. Okay, so you're probably sitting here thinking, why is this important to me? When we talk about regional interdependence, it refers to the concept that seemingly unrelated impairments in a remote anatomical region may contribute to or be associated with the patient's primary complaint. So how many patients do you have on your schedule that could have the diagnosis neck pain, shoulder pain, low back pain? So this is the surrounding area that, sometimes if there are some nagging symptoms, you want to make sure that you look into the thoracic region and rule in or rule out any surrounding impairments or movement dysfunctions. It's not often that we will get a diagnosis written on a prescription that will say rib dysfunction. So it's a lot of your evaluation that basically you would have to rule out some other diagnosis. For example, cardiac involvement. Hopefully we don't have anybody walking in the door that would have signs of a heart attack, but you do not know. So that's where you need to rule out a lot of the cardiac involvement, making sure you're checking blood pressure, you're asking all of the red flag symptoms. You also want to ask questions in regards to pneumonia to make sure that you can rule it out. They can get pleuritis of the chest cavity as well, which could possibly present as thoracic pain. Herpes or adverse neural tissue tension of the long thoracic nerve. So that could possibly present as a rib dysfunction as well, but it's not truly a dysfunction, a joint dysfunction. Fractures. You want to rule out any compression fractures of the vertebral bodies. This usually occurs in the lower thoracic area from accepting excessive load, or if somebody is on the obese side, just having the compression of the joints and the body. Rib fractures. The majority of the time there must be a history of a trauma. The only time that you'll really experience a rib fracture without trauma is if somebody has some type of bone weakening disease such as osteoporosis and they have a strong cough or something of that nature. And the sternum, you want to rule out any fractures there, and again, direct trauma. So football players, especially in high school and adolescence when bone maturity is still growing, or in little league. Structural defects that could lead to some issues in the rib cage: scoliosis, which we're all familiar with, kyphosis, and ankylosing spondylitis. Kyphosis, more when we're talking about Shermans disease, it's more of a degenerative process. It's not inflammatory. Some signs and symptoms: the patient will actually start with pain after a few years of the deformity being visible. So yes, they can be complaining of that pain. It's not usually a severe pain. It's more of a slow increasing pain, whereas with a rib dysfunction, most time you'll have the severe pain associated with it. And also with the kyphotic structural defect, pain usually is brought on by heavy labor, which can also increase throughout the day, and they experience fatigue in the mid-back area. It's not as localized. Ankylosing spondylitis, it's chronic rheumatoid disorder that usually affects the SI joint. It's progressive and it spreads to the thoracic spine and the costovertebral joints. Periods of relative inactivity that could be interrupted with exacerbations, severe pain, and restricted motion. And that's usually, it starts to develop in all planes. It's not just in one plane. Average onset, 25 years old, higher incidence in males, and there is a hereditary factor. So somebody, a younger male, could be 20 times more likely to experience that than the female. And thoracic disc dysfunctions. We don't really think of that a lot. There are definitely fewer problems with thoracic discs as compared to cervical and the lumbar regions. But in the thoracic area, all derangements will be in the posterior or posterolateral directions just based on the anatomy. So they can easily be treated with an extension type treatment approach. The reason why there's fewer problems in the thoracic area is the intervertebral foramen is larger in the thoracic spine, and the nerve root is responsible for a smaller area. So we don't really have, the dispersed dermatomes and myotomes as we do in the other areas. But this could result in anterior chest pain, sudden onset of the thoracic pain, with radiating symptoms into that intercostal region. Average onset is in the 40 to 60-year-old age range. All right, there are some articular conditions that you should rule out before treating rib dysfunctions, costochondral conditions and sternomanubrial conditions. Costochondral, we mentioned, caused by direct trauma, and you'll typically have pain and swelling. It will be tender to palpation. And sternomanubrial usually results from a hyperflexion type of injury. All right, so getting into the evaluation aspect. So typical evaluation, you're looking at posture, you're looking for some of the structural defects, cardinal plane movements, so your typical flexion, extension, side bending, rotation. You want to look for patterns of pain and limitation. So we'll touch on that when we get to the movement dysfunctions. Neurological exam, there really is not a whole lot for the thoracic spine. There's no deep tendon reflexes, but what you do want to rule out is any central nervous system involvement to make sure that nothing is referred. Segmental mobility testing, just checking for movement between the interspinous spaces within the thoracic spine, and also when we do I'll demonstrate some spring testing, just comparing for one segment to the next. There are two special tests which we'll touch on, and then palpation, so you're palpating the joints, the tissue, looking for any tissue texture changes, comparing side to side, and then also, to normal. All right, so thoracic facet joints and costovertebral joint dysfunctions. Thoracic facet joint, you'll usually have the unilateral limitation in range of motion limitation with just rotation, not side bending. So ribs result in a side bending limitation, and thoracic facets will result in a rotation limitation. Thoracic facet joints present with asymmetrical segmental mobility findings, so you'll usually be able to palpate the change in the movement from one segment to the following segment, and then the tissue texture and positional fall. Costovertebral, you will get the sharp pain. It's still unilateral like the thoracic facet, but the side bending is the predominant restriction, and this will have problems with deep breathing, sneezing, and coughing. So it's not to say that you can't have problems with breathing, sneezing, and coughing if you have a thoracic facet dysfunction, but they're a lot more prominent when it is a true rib joint dysfunction. Rib 1, we probably see this a lot more than we realize. Rib 1 dysfunctions can be caused by direct trauma. If someone's doing an aggressive pushing or pulling type injury, they have a Fuchs injury, or if there's a cervical facet joint dysfunction, especially because of how the scalene's attached to the rib. So you want to make sure that before you do any manual therapy techniques to rib 1 that you're ruling out the presence of the cervical rib. If they've had x-rays, you can see on the report, it would be listed on there. You can contact the doctor. I know there's another way that they palpate. If rib 1 is higher and it's up to about 1 centimeter difference, you suspect a joint dysfunction. So you're just having them either sitting or supine, and you're palpating. And if it's more than a 2 centimeter difference, you're suspecting that there's a cervical rib present. So again, play devil's advocate. The reliability on that isn't the greatest, but you know, it's what we have in the clinic. With rib 1 dysfunctions, there'll be restricted rib mobility with inhalation, exhalation, or both. Asymmetrical rib springing, possible swelling and point tenderness. I would say more so the point tenderness. And rotation of the head towards and side bending away would be restricted. And essentially that is, you have them rotate all the way to the side, and then you're having them try to bring their ear down towards their chest. So that would be restricted there. And that would be assessing this side here. Shoulder range of motion is most likely within normal limits, but you could get some end range pain with rib 1 dysfunctions. So if you have that patient, you know, you're getting them back, they just have that final, they have full range of motion, they're having some pain at end range, you want to try to rule out the surrounding joints, it might be worthwhile to look at that rib 1 just to make sure everything is in good alignment. And then there are no neurosigns with rib 1 dysfunction. All right, so the special tests that I referred to before, you have compression and distraction. So that you can do for the thoracic spine is best done seated. So we've seen those tests before where you're coming in from the superior aspect and just giving a compression force down through the patient's shoulders. So it's only maybe 10 to 20 pounds of pressure that you're really putting through the body. Should not be painful. If they say that there is a lot of severe sharp pain, you want to rule them out to see if there's anything else that is going on. And a percussion test, you're using the ulnar aspect of a loose fist, and it is just a light tap on each spinous process as you go down the spine. Again, not expecting that to be painful, possibly uncomfortable if there is a joint dysfunction or irritation of the surrounding tissues. But if they have complaints of deep pain, nausea, or any visceral pain, you need to refer them out because that's indicative of serious pathology. All right. So we're going to go over just some rib testing here, just in 3 different positions. If you don't mind, Allie. All right. First, sorry. Okay, so basically what you're looking for here, if there are any anterior or posterior positional faults of the ribs. So taking, I'll try to stand up right here. Normally would be directly in front of the patient, so you're not skewing your own results. So you're coming right off of the sternum, making sure that you're on the same level. So you would want to start at the clavicle and work your way down. So rib 2 is the first palpable rib under the clavicle. Making sure you're right on the sternum, you're feeling for the grooves, and then for the joints. And then you're just looking for positional faults. So if one finger would be deeper, here it would almost feel like it's a softer type of end feel, and that would mean that she has a possible posterior positional rib. And then I would want to come on the posterior aspect, check that same level, because then that same level should feel prominent. Okay, and then you would check each level going down. Okay. So this is just some general inhalation, exhalation assessments. So the patient is just lying in their comfortable position. We're going to check upper ribs. So we're just coming, you can come from the cranial aspect, or you can come underneath and have your fingers right under the clavicle here, just checking the upper ribs. So I have her take a deep breath for me. You're going to hold it when you get in it, and breathe in a little bit more. Good, and exhale. And exhale some more. And relax. So what I'm feeling for is just expansion, which she takes that extra breath. Spin around, sure, you might spin it around.
It's a lot.
When she's taking that extra breath, you're checking, for accessory muscles and excursion. You're just checking to see if it's symmetrical side to side, painful, and then if you feel like there's a specific rib that you want to test, you can just change your hand position to be a little bit more localized. If we want to do the lower ribs, we're just standing down at the hips on the side of the patient. Go ahead and inhale, hold it, inhale some more, good, and exhale, hold, and exhale some more, good, and relax. The same thing, you're just checking for excursion and symmetry. And spring testing would be so comfortable with the program here. That's fine. So lower ribs, so now this is more into the movement assessment of the actual joint. So we're going to do just a stabilization. It's a cross-handed technique. So I'm stabilizing the contralateral side, testing on this side here. So you can just do a broad hand placement at first, just like we did with the breathing. And again, this is stabilizing. So once you get your position, that is not moving, and I'm just springing, and then as I feel like I want to localize into the different ribs, you can change your hand position. So you're right on the rib here, and you can just fold over it and coming in and assessing there. So you're assessing spring. You can also take it to end range and make sure that each rib has the full excursion. If you're doing upper spring testing, stand here for the ribs, not the most upper ribs, but I would say rib 3 through 5. You can essentially do it here. You're stabilizing. It's best if their arm is abducted a little bit, because it actually takes their scapula out of the way, and you can get right on the ribs. If their arms are by their side, that may block your assessment a little bit. And you're just coming in as general. Again, you should be doing one side at a time, because if you're doing this, you're not really sure what's moving and not moving. So stabilization is key right off the spine, and then this one is really good to come in and assess one at a time. Any questions on the assessments? I'm just going to jump into a few treatment techniques. Are you okay in that position? I'll just change the order here a little bit. All right, so let's go sideline facing them for me, please. So this is the lower rib separation. Okay, so this would essentially be if you had an inhalation or an exhalation restriction, okay, and you really want to get in there and separate those ribs. Same technique if you want to use it for an inhalation restriction, you're going for the upper rib. If you're using it for an exhalation restriction, you're going to be working the lower rib in the hand position here. So it just wouldn't matter your exact placement. All right, so you're taking your hand, finding whatever level that you found your restriction at. First thing you want to do is you want to place your hand right in the space of the rib. So you want to find that exact rib. You're basically holding down that area. You're bringing the arm up just until you feel tension, just until you feel that rib start to move. Okay? And go ahead and take a deep breath for me. And exhale. And then, so again, if this is an exhalation restriction and I'm working the lower rib as she's exhaling, I'm actually giving a little bit of pressure on her exhale and then holding it at end range. And then she can take another breath. And exhaling, I'm pulling her arm in that cranial fashion just to create some tension there to lock out and giving a little bit of pressure through my right hand here as well. Good. You can do that for about 3 to 4 reps, and you want to do that several sessions just till you feel that the rib is starting to move again. And if it's the inhalation restriction, the hand placement is the same. It's just on her inhale, you would want to work with her breathing. Okay. This is the upper rib separation. So she's supine. Same thing. We're working with the arm here. So I'm essentially going to be pronating my hand using the web space, and I'm finding. Are we on the other side? No. I'm finding the rib. The same concept is the same inhalation restriction. You're using the upper rib from your stabilization hand, and exhalation restriction would be the lower rib. But you're getting into that position with the pronation, holding it here, bringing the arm up to take up any slack, and then go ahead and take a deep breath. And exhale. Good. And I'm working the lower rib on this one. Then I maintain that pressure, and I can have her go through a couple more breaths. So you can be pretty specific based on your evaluation. So pretty much everything, just like any other technique that we do, you want to do a post test and follow it up by some breathing techniques for home. While she's here, we'll do the supine rib 1. This is partial assessment, and then also we'll turn it into a treatment. If they were on a table with their feet supported, one of the things that you can do is you can side bend their head. You're coming in, remember that rib 1 is the most curved rib, and it's oriented inferiorly. So your hand position, you should be coming out to the side. Force, basically hand and elbow, is coming towards that opposite hip. Okay, and you want to be in a direct line. I don't want to be pushing down this way into the table. So I'm here, getting in good position. I'm wrapping around. I'm on rib 1. For assessment, this is just a little bit of a spring test. What you should see is the opposite foot should actually have a little bit of wiggle in it. If there is a rib dysfunction here, it doesn't transfer the movement down all the way into her foot. So that's just one little quick assessment besides feeling for what's going on at the rib here. So you could turn this into a mobilization. Same thing, you're just getting that web space here, taking her into that mid position, and making sure I'm coming down into that inferior. You can do grade 1 through grade 5 with this technique. And when you go seated, try the chair. I prefer the supine rib one just because I am shorter, so a lot of times it's hard for me to get in the best position. I think it would work in this case. So you could do seated rib 1 here. Same thing coming in. What you would want to do is you want to just side glide the patient a little bit to take up some slack and add some side bending. You want to make sure you're not doing this. That's very, very uncomfortable. Oh, I thought you were bringing it for the stabilization thing. They can put their arm here. This is the best to, so if the arm's hanging down, they can put some tension on the muscles and won't get the best results. But they're nice and relaxed here. Everything's in neutral. So taking up some side blunting, she obviously is very hypermobile, so she has a lot of motion. So if we just do a move, we want to make sure it's going in the correct spot. And you want to side bend the head towards, just to take up some slack. Again, do not do this. When you're doing the move, also don't do this, because that's very uncomfortable with the patient. So you're just holding and stabilizing here. And make sure your elbow's up. Your position of the force is going down towards the opposite hip. And again, this can be grade 1 through grade 5. In grade 5, you just want to make sure you have a good lockout, and then you can just thrust at end range. Any questions on those so far? Okay, and rib 2. Maybe if you can just face that, so they can see. Thank you. So rib 2, a lot of times if it's elevated, it's going to be best to, especially if you're going to do a grade 5, to do this in this position here. This is hard to come in from the front to grade 5 it. And essentially they're seated, comfortable, you're coming in, so you're standing to the side, using your evidence here, you're finding rib 2. So with this one, you really have to get your elbow up, okay? And then the force is coming through this hand, okay? So this is really just stabilization. So once you find rib 2, you're taking up the tissue slack. So if you did a mob and you didn't have the tissue slack, you would just slip right off. So you want to make sure that you're taking up that tissue slack. Now I'm right on bone. I'm coming in, making sure that force is here, and I can come in this way. Usually, again, I would prefer her a little bit lower so I had better body mechanics. And then that way, now I'm getting both hands driving through, and then you're just dropping your body. Again, grade 1 through grade 5. And then a seated, like a muscle energy technique. While you're here, I'll show you one. So basically, you can't use this on every patient based on your size or their size, but you're going to go ahead and take this. So I'll have her turn around. I'm just going to show you placement on the back, and then I'll have you turn around so you can see what she's doing in the front here. But essentially, so this is to correct the anterior, posterior subluxations. So I'm coming in, and I'm essentially going to be placing my hands, which you'll see in a second, standing behind her, okay? And you're locking out. So depending which rib that it's at, your position is going to be slightly different. You have to find the end range for that rib and the end range for that patient, okay? So you're coming in. Good. So I'm bringing her forward, trying to find restriction. We're just going to say she is restricted here. Okay, right back. So now it's almost like a bear hug style, okay? And I'm going to have her try to take this elbow up towards the ceiling. So good. And relax, and you really want to try to get the rotation component of it as well. So let's just go around. So her force is really coming through her elbow. She's not trying to overpower me. So she's essentially creating a fist. If it's an upper rib, she can take her fist and put it here and put her hand over just to localize it a little bit more. And then the elbow actually gets positioned at whatever the rib level is. So if it was a lower rib and she wanted to do here, she would keep her elbow down here. Upper rib, she's going to lift her elbow up in this direction. So when we position her and she goes to put the force, it's going to drive the pull right at that rib level. Rib dysfunctions. Good. Okay. So I'm going to come in. This is really supporting for me, and I'm grabbing here. So you can either hold your hand behind the elbow, or you can hug around this way, as long as you cue them, okay, to make sure that they're getting a rotational component, but the push is really coming through this back part, okay? So go ahead and push. And I'm resisting. I have body contact over here because I'm resisting that rotation, okay? Depending which way the rib is, if it's anterior position or posterior position. So with that one, I had her positioned when she was coming posterior. You can also do a setup where they're going the other direction and basically pulling the anterior. So it's very similar. It's just which way they're pulling. It's the resisting pull.
Or when you're feeling for, what exactly are you feeling for when you're getting her in position? Does the rib stop moving at that point? You take her all the way to, where it doesn't move anymore?
Very close to it. So just like similar to if you did any other joint move in the spine, you would want to lock everything out above or below. So I'm just feeling for when motion starts to occur at the level above. So I know when I'm going to do that move, the force is going to go right where I want it. Sorry. Any other questions? Thank you. I guess I should sit online if they have questions. Actually,
Does anybody online have any questions?
So I do have a case study or two that we can talk about, but I mean, I know time-wise, I don't know who needs to leave, so if some people want to stay and we can chat about it. Discuss it? Okay. All right, so distract me.
Yes, pretty much. There you go.
All right. Okay, so talking about repetitive type injuries, when I did my fellowship training, I was down at basically a place that was a lot of workman's comp, repetitive type. You would see the patients actually within hours of injury, which was amazing in a way that if they had a acute joint dysfunction, you could treat it, and sometimes by the following week they would be gone. So in those cases, if you actually had an acute rib dysfunction, and they would be a candidate for a grade 5 mobilization. Sometimes, they're better in 1 to 2 treatments. Okay, so that's usually not the case that we see. So I'm going to discuss this case. It was actually, she was around 45. She worked in the toll booth. And so one thing, you're always reaching with that left hand. She was very short. She was, I think, 4'11", and she was obese and very out of shape. So she had just started this job, maybe about 3 months into it, and she started getting this nagging pain in her mid-back area. And finally, one day, when she reached up, it was real busy, she reached up real quickly. It was a higher truck, and she felt a pop in her left mid-back area. So she presented, we obviously ruled everything out. So a lot of things that I mentioned that are just being out of shape. So the musculature is not going to be working as well to support that area. So you're reaching like this, you're exposing the rib portion in the back, which makes it very vulnerable. So she had some pain. She could do her daily activities. It was more nagging type of symptoms, but she only got the sharp pain when she reached all the way up, okay, and if she sneezed. Everything else, was just like a muscular discomfort. So was definitely not, they say go with your gut when it comes to a grade 5 mobilization. It was not something that I wanted to do on the first try. So actually, we just did a lot of muscle energy techniques. She actually ended up having a rib 3 subluxation just from coming up and reaching. It was a long recovery for her. So this is what you'll see if it's a chronic type of rib dysfunction. They will not get better in a few visits, just because there are a lot of things that are leading up to the presentation. So essentially, we do a lot of the muscle energy techniques that I showed on Allie, and a lot of thoracic type mobilizations. If they come in and the rib is very sore, okay, the last thing they really want you to do is poke on the rib. So doing indirect mobilizations is usually more beneficial for you, because you're going to develop the trust of the patient, and then you can try to go to more specific rib mobs in a few sessions. So that's basically what we did. Is we did a couple muscle energy techniques. It was really, she was really sore, complaining. Things got better. She probably was there closer to about 2.5 months, but you think, she's working the whole time, and the aggravating injury, she was doing this for 8 hours every day, so it took a longer time to recover. So you want to do your basic evaluation, and essentially, if there's poor scap stabe, you want to work on that. If it's sitting, if it's movement dysfunctions, which in this case that was what ultimately led, there was no direct trauma, you want to address that. So yes, the rib dysfunction, but then you have to work on reaching, sitting, core. I mean, whatever. In her case, that's lifting. That's what we worked on. So that's just a generalized case for that. We also have or had somebody recently in the clinic that was a direct trauma, okay, and it was a true joint dysfunction. So essentially a few visits. It was eval plus 2 visits, grade 5 mobilizations, which I didn't show today. It's very similar to the supine grade 5 thoracic technique that I'm sure most of us have seen. If not, I can go over it. But with that one, you actually just roll the patient closer to you, and your grip is like gun grip, basically right on the rib. It's not the most pleasant mode, but it is extremely successful if you can get in there and the patient can relax, and it can be done quickly. So we did that onto the rib, and we did some thoracic rotations, mobilizations, just end range mobilization with movement, and then a lot of thoracic rotation for home exercise program and in the clinic. So essentially, if you're missing the rotation, it's going to cause the surrounding areas to overwork, just like anything else. So that rib, in this case, did have trauma, but most likely some of the other situations were leading him up to this. So a couple things that you can do after you basically increase the motion if they are a candidate for it. It's called a thoracic whip. And you get positioned or whatever level that you want to be at. You basically can do the fist like we were doing without, if you want it to be more unilateral, or just hand over hand, sitting up nice and tall. You're putting something, usually ball, so you don't want your legs adducted, you want it in a neutral position, and they're squeezing, so they're locking up the lumbar spine, elbows at the level where they're at, and it's a thoracic whip. Okay, they go really fast to train them in the clinic. Obviously, you want to make sure that all of the joint dysfunctions are essentially resolved, because if they do this improperly, they can actually flare it up. But it's a really good home exercise program, and you're having them come back here trying to drive that specific segment and getting that rotation. So to train it, you can stand behind, have your hand, sure, as can have an imaginary. All right, so we'll just pretend we're doing this function like this. All right, so she would be doing a thoracic whip here, okay? Again, she's hypermobile. She rotates a lot through her lumbar spine, so we want to make sure she's localized. So I'm going to train, get it? I'm going to train her to keep that shoulder locked out and rotate this, so this is going to hit, okay? And then come back to neutral. Now she's going to do it as fast and powerful as she can. More powerful. I really think that was. Like really this is their time to get back at you. And you want to do about 10 or so, okay? Whatever they can tolerate, as long as it's pain-free. One, because that really, it's a good way to use the motion after you just did a mobilization to gain the motion. And it's something that you can have them take home with them. So essentially, treatment for rib dysfunctions is very similar to everything else we do. You're just restoring motion, making sure that they maintain motion by using it, and then stabilizing. If it's a true weakness, you have to strengthen. If it's just a neuro-re-ed, this is something that works very well. A lot of times we just get stiff and we tend not to rotate the area. Our lumbar spine and our cervical spine takes the hit, so you just want to try to teach that thoracic movement. Any examples of patients that you have in the clinic right now that you have any questions on? Sorry. All right, well, if there are any other questions, feel free to shoot me an email or any case studies and we can talk through them. Thanks.